Complex regional pain syndrome, or CRPS, stands as one of medicine's most challenging and often misunderstood conditions. An insightful discussion recently delved into the nuances of this painful disorder, shedding light on its diagnosis, underlying mechanisms, and cutting-edge treatment approaches. For clinicians, diagnosing CRPS relies on the Budapest criteria. This framework requires the presence of persistent pain that is strikingly out of proportion to any initial injury. Beyond this hallmark symptom, patients must report at least one symptom in 3 of 4 specific categories, and clinicians must observe at least one sign in 2 of these same categories. These categories include sensory changes like hyperalgesia or allodynia, vasomotor abnormalities such as temperature or skin color differences, pseudomotor changes involving edema or sweating, and motor or trophic signs like decreased range of motion, weakness, or alterations in hair and nails. Delving deeper, the episode highlighted that CRPS is fundamentally a nociplastic pain disorder. This means the intense burning pain patients experience stems from a profound disturbance in pain processing within both the peripheral and central nervous systems, rather than from ongoing tissue damage. This distinguishes it from nociceptive pain, which originates from tissue injury, and neuropathic pain, which results from a nervous system lesion. The presumed pathology involves neurogenic inflammation, where sensory nerve endings release neuropeptides, leading to localized warmth, swelling, and redness. In more chronic cases, the central nervous system itself becomes hyperexcitable, a phenomenon known as central sensitization. This helps explain why pain can be so severe even when the initial injury is minimal or fully healed. One of the most unique and fascinating aspects of CRPS is the distorted perception of the affected limb, often accompanied by motor neglect. Patients frequently describe their painful limb as feeling foreign, alien, or even strangely sized, either larger or smaller than reality. This body perception disturbance signifies a breakdown in the brain's internal map of the body. Interestingly, treatments like mirror therapy are specifically designed to address this by providing the brain with corrected visual feedback, aiming to restore a more normal and accurate representation of the body in the brain. When it comes to treatment, timing is crucial. For acute CRPS, typically within the first 4 to 6 months, a short, high-dose course of glucocorticoids like methylprednisolone tapered over several days can help reduce inflammation and pain. Bisphosphonates have also shown a modest benefit, likely due to their anti-inflammatory effects and their action on the patchy bone demineralization often seen in CRPS. It is important to note, however, that these specific interventions are generally not recommended for chronic forms of the condition. Shifting to chronic CRPS management, the preferred pharmacological agents move away from opioids, which are generally ineffective for nociplastic pain. Instead, the primary strategy focuses on agents that target central nervous system sensitization. First-line options often include tricyclic antidepressants like nortriptyline or amitriptyline and SNRIs such as duloxetine or venlafaxine. These medications not only help reduce pain but can also improve sleep, which is often severely disrupted in patients with chronic pain. A particularly insightful point from the discussion emphasized that standard aggressive physical therapy can actually be counterproductive for CRPS. Instead, effective rehabilitation often involves more nuanced modalities, like graded motor imagery. This hands-off approach aims to calm sensitized nerves, reduce skin sensitivity, and improve movement, ultimately restoring function by gently retraining the brain and nervous system. Encouragingly, the episode shared a positive outlook on prognosis for many. Approximately 80% of patients experience a single episode of CRPS that significantly improves or resolves over time. The bulk of this recovery typically occurs within the first 18 months after the condition's onset. Furthermore, there was a valuable insight into prevention. Administering 500 milligrams of vitamin C daily for 50 days following a distal radius fracture has been shown to reduce the incidence of CRPS. This is believed to be due to vitamin C's role as an antioxidant and free radical scavenger, which can help mitigate the intense inflammatory response post-trauma. Finally, emerging research suggests that CRPS may even have an autoimmune component. Studies have identified circulating autoreactive IgM and IgG antibodies in patients with CRPS, adding another layer to our understanding of this complex disorder and potentially opening doors for future targeted therapies. The evolving understanding of CRPS underscores its intricate nature and the ongoing efforts to better diagnose, treat, and ultimately prevent its debilitating effects.